Good afternoon and welcome to this ERKNet webinar. My name is Francesco Emma and I'm speaking from my office in Rome. As usual, before starting, let me remind you that your microphones are turned off, but that during and after the webinar, you can send your question through the application that is present in your screen. I will then ask your question at the end of the presentation. The webinar will last approximately 30 minutes, and you will then have 15 minutes available for question approximately. So our speaker today is Lutz Weber, who is a professor at the University of Cologne in Germany, and he is the chief of pediatric nephrology and dialysis unit and the head of the pediatric renal transplant program at the Children's and Adolescent Hospital in Cologne. Professor Weber has multiple interests in pediatric nephrology, and he's been the lead investigator in multiple studies, in particular studies on nephrotic syndrome, genetic renal diseases, and renal transplantation in children. The title of his talk today is Primary Therapy of Nephrotic Syndrome. So thank you very much, Lutz.
Francesco, thank you very much for this awesome introduction, and good day, everybody. It's my great pleasure to discuss this interesting topic today with you. So today's agenda comprises a short introduction to the topic, and the main part will be on primary therapy of nephrotic syndrome, and we will finish with a perspective, and I'm going to introduce two ongoing studies. So probably everybody of you knows the typical clinical appearance of nephrotic syndrome in childhood, and you can see here the typical so-called renal edema in the eyelids and also in the extremities, in the scrotum, and in severe cases you also see ascites or anasarca. And with that clinical appearance, so if you then find heavy proteinuria and hypoalbuminemia, you then define the status of nephrotic syndrome, and you know that the characteristic symptom is edema, and you normally find dyslipidemia. We have to differentiate between primary nephrotic syndrome and secondary nephrotic syndrome, and in those we see genetic and idiopathic forms, and the idiopathic nephrotic syndrome is the topic today. As far as secondary nephrotic syndrome is concerned, there is infections, drugs, and also malignancy that cause this condition. So the clinical manifestation of steroid-sensitive nephrotic syndrome is reflected by a relapsing disease. And with that picture here, you can see that it is more than 50% of patients that will develop a relapsing course of the disease. And this is of special importance because despite being a relatively benign disease that we can treat quite good, the families are often left with fear and sorrow due to the relapsing course of the disease. So there's a number of histological manifestations that can result in the clinical pictures of nephrotic syndrome. The most frequent one definitely is minimal change disease in about 80% of patients. But the histological diagnosis does not predict the clinical course of the disease. And just a few words to pathophysiology, which I have to admit we don't know much about. So this makes also the treatment quite difficult, because if we do not know the exact reasons for nephrotic syndrome, we don't know exactly how the drugs that we administer take their effect in this disease. But we all agree on the point that the podocyte potentially takes a central role in the pathophysiology of the disease, and the podocyte is here nicely shown in this picture here. So if we put the podocyte into the center of damage, we do know that there is a number of factors that will produce podocyte damage that translate into, histologically speaking, into effacement of the podocyte, and then results, clinically speaking, in nephrotic syndrome. So potential T and B cell disturbances are just another side of the disease with the podocyte. So what we have to consider is that idiopathic nephrotic syndrome, and the term idiopathic already shows that we do not know exactly what the reason for the disease is, and in these situations, physicians tend to call a disease idiopathic, is not necessarily minimal change disease and is not necessarily steroid-sensitive nephrotic syndrome. At the same time, steroid-resistant nephrotic syndrome does not necessarily mean that it is FSGS, because we do know that there are patients with minimal change disease that may be steroid resistant. At the same time, there's a number of FSGS patients that would respond to steroids. So coming now to the main part of the talk, it is primary therapy. And if we try to define some treatment targets, we would all agree that treatment should be efficient, that there should be no only little side effects. We would like to have no relapses thereafter, and we would prevail the good prognosis as far as renal function is concerned. And we basically have two sides of therapy. The one side is the symptomatic, or if you want, non-immunosuppressive form of therapy, and the other one is the immunosuppressive therapy. And we all know that the typical sign of nephrotic syndrome is proteinuria, and what proteinuria does, that is that it provokes edema. So how do we treat edema? And for that it is important to understand how edema form. And there are two theories about that. And the first one, which is most famous in the pediatric situation, is the so-called underfilling theory of edema. And just to sum up this quite busy slide here, but it's really worthwhile to go through it slowly when you have more time, perhaps later on, is that proteinuria via the decreased oncotic pressure forms the edema and then results secondary in distal tubular sodium reabsorption and water reabsorption. The second theory is the so-called overfilling theory that is less popular in the pediatric situation, but here there is a direct primary sodium retention due to the kidney disease, and the epithelial sodium channel, the ENaC, plays a central role in this theory here. But besides the theoretical aspect, it is of major importance to really understand if your patient has an intravascular underfill or an intravascular overfill. And different groups have suggested different aspects to differentiate these two states of volume, and they have proposed hormones or for example, concerning GFR, serum albumin concentration, whether there is hypertension or hypotension, and also taking histology into account. But with these parameters, we have to consider that sodium excretion and hormones are only useful before any kind of treatment has started, may it be antihypertensive, diuretic, or even immunosuppressive treatment. And here, for the more clinical aspect on the right-hand side, you will certainly agree that the histology may not be useful in the primary evaluation of your patient, because you just don't have the histology, and most patients with steroid-sensitive nephrotic syndrome will never be biopsied. So this is why I would like to show you this very nice picture here that I found in the wonderful overview from the Manchester group about the non-immunosuppressive therapy of nephrotic syndrome. And this is a modification of what the Indian Association of Pediatrics have proposed for assessment of edema in those children. And you can see easily that it has great influence on further treatment, whether your patient has intravascular expansion or intravascular depletion. Being fluid restriction in the first condition, and even use of diuretics, and it is more fluid administration in the case of intravascular depletion. So this really is an important measure right at the beginning of the evaluation of your patient. So if you decide treatment of edema has to be taken, you probably would start with a low sodium diet, but the basic and central part is definitely fluid restriction and the use of diuretics. And because of the potential threat of intravascular depletion, you have to watch out for hypovolemia. The application of albumin is indicated in treatment-resistant and even life-threatening edema, and should be followed by a furosemide application intravenously. But again, here you have to watch out whether your patient is hypervolemic and has a hypertension, because then there is a lurking danger for pulmonary edema. In reality, however, I think that a lot of centers are more permissive with the use of albumin infusion and not restrict it strictly to those that are treatment resistant or have life-threatening edema. So in case that you use furosemide for treatment of edema, it is important to know that you need higher doses due to high tubular albumin binding of furosemide and the subsequent reduced efficacy. Please take care of hypokalemia, especially if you combine the furosemide with thiazides. Amiloride has the theoretical advantage of blocking the ENaC that, as I have mentioned before, has a central role in the overfill theory of edema formation, but it has never been shown to be effective in randomized prospective trials in children and is off license. I need to mention that there might be loop diuretic resistant in nephrotic syndrome due to the activation of the renin-angiotensin-aldosterone system, and in these situations, it might be of value to add thiazides or mineralocorticoid receptor antagonists to the therapy to overcome the edema. Also, nutrition is important in the primary care of nephrotic patients, and we have already mentioned the recommendation of a low sodium diet for edema treatment, but you have also taken into account that the protein intake should not be less than 100% of the recommended daily allowance. You might considering to avoid excessive supply of saturated fatty acids due to the dyslipidemia in nephrotic syndrome, and especially in glucocorticoid therapy, you might consider to decrease the intake of carbohydrates and the intake of fat. So summing up the important complications in nephrotic syndrome, we have talked about hypovolemia due to low oncotic pressure, but we have to talk about immune deficiency, which is caused by altered cellular and humoral immunity and disturbances of the complement system, and the risk of thromboembolic disease, which is due to the imbalance of coagulation factors. For example, there is an increase of high molecular weight procoagulants such as factor 4 and 8, and there is a decrease of low molecular weight anticoagulants such as antithrombin. We also observe reactive thrombocytosis and platelet dysfunction in nephrotic syndrome, and together with hypovolemia, there is a hemoconcentration. Of less importance, especially what the need for direct action is concerned, I would like to mention hypothyroidism and dyslipidemia, but those two conditions may be of great importance in case of prolonged heavy proteinuria. So if we take a look at infections, which is definitely the #1 cause of morbidity in nephrotic syndrome, we are faced with cellulitis, with pneumonia, especially in those below 10 years, urinary tract infections in those above 10 years, peritonitis, and more rarely sepsis and osteomyelitis. Of note, the first significant decrease in morbidity of nephrotic syndrome took place with the introduction of antibiotics treatment, even before the introduction of steroids. The reason for the high infectious risk in nephrotic syndrome is low IgG, is abnormal T and B cell function, is the complement disturbances, and last but not least, immunosuppressive therapy. The problem for bacterial infection definitely is encapsulated bacteria such as Streptococcus pneumoniae, but there is also a danger from viral infections, and I would like to point out varicella zoster virus and influenza virus here. So is there any reason for prophylaxis of infections in nephrotic syndrome? So this is very controversial, and we certainly have to take into account the risk of resistances. And there has been a very nice analysis by McIntyre and colleagues quite a number of years ago, but they have calculated that there need to be 110 children need to be treated for 1 year to avoid just one episode of pneumococcal infection. So the center of prophylaxis definitely nowadays is vaccination, and this comprises pneumococcal vaccinations, and you should go for at least 2 vaccinations with the conjugated vaccine in those below 2 years of age, and you should go for the polysaccharide vaccination in those above 5 years of age. It is recommended to have yearly influenza vaccination in children suffering from nephrotic syndrome, but you should use the inactivated vaccine here. When varicella zoster virus exposure happens and you're not sure whether your patient is vaccinated and you cannot trust the titer due to uncertainties in proteinuria, you should go for passive varicella vaccination within 4, maximally up to 10 days after exposure, or you could opt for oral acyclovir treatment 7 days after exposure for 7 days. It is a bit out of the scope of this webinar today, but I would like to hint at this well-performed study from the Japanese group of Kamai and co-workers investigating the potential role of live vaccine in nephrotic syndrome under immunosuppressive therapy. And what this study has nicely shown is that live vaccination is possible in well-evaluated patients with a good immune system, as is shown here in the inclusion criteria. So the second leading cause of mortality in onset nephrotic syndrome is thromboembolic disease, and this can be venous and arterial. Most often you see deep vein thrombosis, but I put venous vein thrombosis in bold here because it's so important to perform proper diagnostics if the children complain about severe headache or if they have vision disturbances. As far as prophylaxis of thromboembolic disease is concerned, it's again very controversial. And what we know is that early mobilization is potentially the best prophylaxis that we can offer. In case you decide to use low molecular weight heparin in severely ill immobilized patients, you should consider drug monitoring via anti-10A levels, and you should take special attention in children with low GFR. You probably need therapeutic drug monitoring more often, and you should not use it in anuria due to accumulation of the drug in these patients. Another very important point in glomerular diseases always is antihypertensive therapy. And what is recommended is that blood pressure should just be normal in those patients. And the first choice of therapy definitely is ACE inhibition or AT1 receptor antagonist due to their antiproteinuric and renoprotective effect. However, again, given the situation that you probably do not really know whether your patient is intravascular depleted or not, you should pay attention for potential hypovolemia because this might potentate the reduced glomerular perfusion in this situation. Taking into account results of other studies towards blood pressure in glomerular disease, I think we should discuss whether we should bring down blood pressure more to the 50th percentile than to the 90th percentile in these patients. So in summary, as far as non-immunosuppressive therapy is concerned, I would like to take this nice overview from the review by the Manchester group. Again, I'd like to point out that there probably is no room for prophylactic antibiotics in the nephrotic state, nor for thromboprophylaxis, and that vaccination should ideally be performed in the situation without immunosuppressive therapy when children are in remission. Of course, we are all aware that these actions are handled differently, and there's a huge variation from center to center as far as these measures are concerned. So we now turn to the immunosuppressive therapy of nephrotic syndrome, and you can see here an overview of the published protocols for steroid treatment for the initial presentation of idiopathic nephrotic syndrome. And what you can see is that the basic principle is a daily application of a high dose of glucocorticoids for a certain time. KDIGO recommends 4 to 6 weeks, which is then followed by an alternate day application of a lower dose of steroids for another 6 to 8 weeks according to KDIGO. But dose as well as duration differs according to different protocols. And KDIGO, for example, suggests steroid resistance after not less than 8 weeks of oral treatment. Some other groups suggest an additional methylprednisolone pulse, for example, as a French group here, to define steroid resistance. In Germany, we define steroid resistance after 4 weeks of unsuccessful daily steroid application. And this quite busy slide just shows you the nice survey that Georges Deschênes has performed 2 years ago for the European Society of Pediatric Nephrology. And again, you can see here the high variability of treatment of initial manifestation of nephrotic syndrome. And there is hardly any concordance as far as duration of therapy is concerned, the cumulative dose of steroids is concerned, whether there is a tapering at the end of therapy, and whether they would use IV methylprednisolone for definition of steroid resistance or not. So this is basically the consequence of the fact that we don't really know what really does the disease, and without the knowledge about the real causes of the disease, it's very hard to define the effects of the drugs that we administer. So what we know from glucocorticoids, that they have genomic effects and non-genomic effects, and especially in nephrotic syndrome, there is some more effects, for example, podocyte protection, stabilization of actin filaments in the podocytes, and potentially a decrease of apoptosis. This has nicely been summarized by the Dutch group of Annette Schijvens and Michael Schröder, and they have also asked the question whether the nephrotic situation condition should result in a different dosing of steroids. And because distribution of the drug is increased in the nephrotic condition due to an increased volume of distribution, and at the same time excretion is increased due to an increased total drug clearance. However, the free, and this is also the pharmacologically active concentration of glucocorticoids remains unchanged in nephrotic syndrome. So that the point is that there is no reason for a dose correction in the nephrotic condition. The other side of the medal, so to say, of steroid treatment is that it is associated with side effects. And this is most often the Cushing-Guid habitus that you can see here on the right-hand side, but there are also other side effects that the parents most often complain about, psychiatric disturbances. And what has been shown very early already is that the longer and the more glucocorticoids you give, the more you are faced with side effects. So the old question is not answered, yes, we might say, whether it is of advantage to prolong initial treatment with steroids. And I would like to answer these questions with the presentation of the most recent study on this topic that have all been very well performed and conducted. And I would like to start off with the Dutch study here from 2013, comparing a 3-month prednisolone versus a 6-month prednisolone treatment course. And it's important to note in this study that the cumulative dose in both groups was comparable. Just summing up, the length of the glucocorticoid treatment had no effect on the relapse-free time within the 4 years of follow-up, and neither did the length of the therapy had an effect on the risk of development of frequent relapses. 2 years later, there have been 2 more studies confirming this finding, one from India, shown here, again comparing a 3-month to a 6-month course of disease. And again, in summary, in the 3-year follow-up, there was no change in the survival free of relapse and in the rate of frequent relapses. Of note in this study, there was a difference in the cumulative glucocorticoid dose between the groups, and a post hoc analysis showed that younger patients, especially those below 3 years of age, seemed to benefit from the longer initial treatment course in terms of survival free of relapse, but not as far as the development of frequent relapses were concerned. The second study on this topic came from Japan, comparing a 2-month versus a 6-month treatment, initial treatment course, and again, the result was no difference in frequent relapse rate and relapse-free survival, but also in this study, there was a difference in the cumulative glucocorticoid dose between the groups. And this is an older study, but I would like to show that even the addition of another immunosuppressant in the initial treatment of nephrotic syndrome, and this is cyclosporin A in this situation, did not result in a amelioration of the sustained remission in patients. But again, in this study, there was a tendency that younger patients below 7 years of age might benefit from the more intense immunosuppression in the initial course of treatment. Peter Hoyer has nicely summarized these findings in his review shown here, and I think this is a very meaningful picture that you can see here, saying that despite how you treat and how long you treat the first episode of nephrotic syndrome, you most probably would not change the long-term, or we could say natural course of the disease. There might be other modifying factors besides immunosuppression, and this, for example, might be age at onset, as I have mentioned beforehand. So where are we right now? What are the findings? We know that initial immunosuppressive therapy should be prednisone, and this is a kind of angel and devil situation because prednisone is associated with side effects. But we also know that extension of the initial glucocorticoid therapy has probably no impact on the natural long-term course of the disease. And this is why future studies should again target initial therapy, for example, with the aim to reduce initial prednisone exposure. And this is exactly what the German Society for Pediatric Nephrology is doing right now within the INTEND study. In this study, a standard protocol with 12 weeks of prednisone treatment is compared to a mycophenolate mofetil arm with reduced steroid exposure. And this is a prospective randomized non-inferiority trial. And we hypothesize in this study that we would see less adverse events in the study groups, at the same time having non-inferiority regarding the maintenance of initial remission. And there is another study that I would like to introduce to you that is conducted internationally with the center in Amsterdam. And I like to thank Antonia Boots for these slides here. This study is comparing the standard of prednisolone treatment with a study group where levamisole is added. And this is a blinded prospective randomized study. And again, here the increase of the primary immunosuppression might have an impact on the occurrence of relapse 1 year after first presentation. So in summary, we have seen that glucocorticoids are the fundament of treatment of idiopathic nephrotic syndrome in childhood. Future studies might change this statement, we will see. The primary response to steroids has prognostic significance because the treatment of primary steroid-resistant nephrotic syndrome is different. Nephrotic syndrome has significant morbidity. We have seen this especially with the example of edema, and complications such as infections and thromboembolic events have to be regarded. As there is hardly any evidence for non-immunosuppressive therapy, this complies with individual needs. The overall prognosis as far as renal function is concerned is good, but we have to consider that the relapsing course of nephrotic syndrome leaves the affected families with fear and sorrow. The intensity and length of the primary glucocorticoid therapy probably has no impact on the natural course of the disease. And so future studies should investigate novel regimen of primary therapy, for example, as I've shown you, with reduced glucocorticoid exposure. So thank you very much, everybody. And I would like to end this part of the webinar now with the announcement of the next webinar, which takes place at 4th of June and is given by Rosa Vargas Poussou from Paris in France on the topic of monogenic causes of hypertension. I thank you all for your attention, and will be most happy to take your questions right now. Thank you for listening.
Well, thank you very much, Lutz, for this very interesting and enlightening webinar. I'm actually I noticed that there was a very strong attendance and a lot of people actually connected to hear your presentation. So to everybody, the presentation is now open to questions. So please go ahead, send in your questions, and meanwhile, until I receive questions, but let me double check because sometimes so I'm still waiting for some questions. Let me ask you a first question, Lutz. I was very interesting about your point on the pneumococcal vaccination. What is your personal view on vaccinating children that are still on low-dose prednisone?
Yeah, of course. I mean, we do know that vaccination, especially with attenuated vaccines, I'm not speaking of live vaccines, is possible in low-dose steroids. But steroids should really be below 2 milligrams per kilogram body weight per day to perform a vaccination. Of course, I mean, there's two sides. The one side would be, would the vaccination be successful? This is the one question that we cannot answer exactly. And the other question is the child at risk due to the low dose immunosuppression? But I think we have seen from the Japanese study that I hinted at that even live vaccine is possible in well-evaluated patients under immunosuppressive therapy besides steroids, if they have a good immune system that can be analyzed.
And really on the same topic, in terms of varicella vaccine, and obviously varicella is one of the diseases that we really don't like in these patients. Do you routinely vaccinate your children once they discontinue the steroids after the first episode?
Yeah, we really try to get all children suffering from nephrotic syndrome to get all vaccinations possible when they are off immunosuppressive therapy. We do know that even vaccinations might be triggers for relapses. We do know that, but we are convinced that the disease as such has much worse influence on the patient situation. So exactly, we do vaccinate our patients.
Okay, so the questions are coming in. The first question is from Ruth Schreiber. She's asking, why treat longer during the first episode?
So if I got the question right, is why to treat longer in the first episode?
The first episode, and it's a very logical question, actually.
So why to treat longer?
Yes.
Yeah.
Well, if I understand well, is why do you treat for a longer time the first episode and shorter times relapses of nephrotic syndrome?
Yeah, exactly. So this is, I mean, I've tried to show you that all the studies that have been conducted in the recent years on this topic showed that prolongation and even increase of the cumulative steroid dose would not have an influence on the natural course of the disease. So really, in my point of view, there is no reason to prolong initial treatment. And now the question is even, can we reduce the length of the treatment? And personally, I would say yes. And the point and the question is, to what length or to what shortage of length is it possible? I mean, the ISKDC protocol suggests an 8-week course of therapy. The German protocol suggests 12 weeks of therapy. The KDIGO protocol suggests something between 12 and 14 weeks of treatment. So there is great variability. And I think at this stage, we do not know what length or what restriction of therapy duration is really possible.
Okay, so I think this is something that in future years we'll probably have to answer. So then Valérie Said-Conti is asking you, in a child between the age of 2 and 5 years who has already received 2 doses of conjugate pneumococcal vaccine, do you give the 23-valent polysaccharide vaccine?
I'm sorry, I think I missed a part of the question. So it's what I
So
understood
if
is
you have a 2 to 5 year old child which has
yeah,
already received a conjugate pneumococcal vaccine,
yeah.
do you recommend to give the 23 valent polysaccharide vaccine?
Yep, probably yes. After the age of 5, we would do another shot with the polysaccharide. Yeah.
Okay, so Marina Vivarelli is asking you, in which cases would you recommend antithrombotic prophylaxis at onset?
Yeah, this is really a very important and very difficult question to answer, because when I'm saying now that it is a gut feeling, it does not really answer the question. So what we try really to define certain conditions when we think a antithrombotic prophylaxis is necessary. So in our center, we really do it in really severely ill patients who have a very low albumin, below 20 or even 15, which are immobilized, who have severe edema, and probably a reactive thrombocytosis. In those patients, we would opt for a prophylaxis with low molecular weight heparin. Would that answer the question? I mean, in Germany, we have tried to invent a thrombophilic score in the patients that, however, failed to show any benefit in the prospective investigation. So I think I would always go for low molecular weights in the severely ill patients with very low serum albumin, which are immobilized and have severe edema.
Okay, so Iman Nureldin is asking, in case of 3 months duration of glucocorticoids, I'm reading her question, is it safe to stop steroids abruptly from the alternate day dose of 40 milligram per meter square, or do we give the dose for 1 month and then taper over the next month?
Again, a very important question that I would answer from the personal experience. Yes, it is safe to stop without further taper. But of course, as I have shown from the survey that Georges Duchesne has published, that there is a huge variability throughout the centers. So I think what is important is if you stop steroids without further taper after 12 weeks of initial treatment, you should keep in mind that if the child experience severe infection or even sepsis or a intensive operation or whatever, you should consider hydrocortisone supplementation to avoid insufficiency in these patients.
Okay, and if you allow me, I would back your question, your answer, and say yes, I agree with you. It's totally safe. If you're on 40 milligrams per meter square on alternate day, we have massive experience now. I think it is safe with the caution that you mentioned. Marina Vivarelli is again asking you, would you recommend routine screening for thrombophilia at disease onset in all children, or only in selected cases?
Yeah, again, a question that we always discuss and have not found a final answer yet. So what I would recommend is to do an exact family history on thromboembolic events. And if there had been any in the family, I would probably go for thrombophilic screening in the patient. Does this help?
Yeah. So basically, you don't recommend systematic screening of everybody.
Not at this stage, but I mean, this is an open question, and
Absolutely,
it's difficult to answer. Finally,
absolutely.
yeah.
So Christy Thomas is asking you, what is your experience of children attaining remission late or with methylprednisolone, will they proceed to late resistant to steroids?
They may. So I think if you look at the data that are out, and if you try to figure out what patients would have a rather complicated course of the disease and who would not, we always have the impression that those patients who respond early to steroids would rather have a uncomplicated course of the disease. Those who would respond late or only after IV methylprednisolone would be more prone to a complicated course of the disease. But so far, I'm not sure whether this is the aspect of differentiation that really gives the answer on what the individual course of the disease is. I'm sorry I have to be this vague on answering these questions, because I think it's really hard to answer this.
Yeah, no, absolutely. And these are open questions that we all have, and it's hard to give a final answer to these questions. Now, we have 4 more questions to go, but I will read to you the next 2 together, and I think you've already answered the question, so I will just basically read them and ask you whether you really want to make any additional comments. These 2 questions come from Georgia Malakasiotti and from Menka Yadav, and they read as follows. So the first one is, do you routinely screen patient for a prothrombotic state, antithrombin 3 fibrinogen levels, and initiate thrombophylaxis in selected cases, for instance in those with marked thrombocytosis, hemoconcentration, or low AT3 levels and high fibrinogen? That's the first question. The second question starts with a thank you for this comprehensive talk, and is asking again on anticoagulation prophylaxis of those with low albumin and thrombocytosis, or of those patients with steroid resistance. The question goes on asking whether you think that aspirin has a role. Does warfarin lead to special issues in view of high protein binding?
Yeah, so I think I have already answered parts of this question, but I would like to come back to the question of antithrombin 3, because this is definitely a factor you should analyze, because you might have to substitute it in case you go for a low molecular weight heparin, just to make sure that it works. So I think you might consider measuring antithrombin, and there is some data out that you might consider low molecular weight heparin if antithrombin levels are below 70 or 50%. So this might be a factor of interest. And another part of the question I would like to come back was in the second part, and let me just recall what it was. I think it was about the aspirin
aspirin, and also if you can make a comment about warfarin.
Yeah, so aspirin, I would be reluctant with that in this age group that we are dealing with, and I'm not sure whether it has an effect on the potentially arterial thromboembolic event. So I would be reluctant in that. And in warfarin, I could only reflect what is written in the literature, because we do not have experience with warfarin here in the center, and there's less experience in Germany, because we normally would not use warfarin in these patients. I'm sorry.
Okay, so Thomas Seaman is asking you whether you have experience with subcutaneous steroids in non-compliant children with frequently relapsing or steroid-dependent nephrotic syndrome?
I'm afraid no. I have no experience, but I would like to, perhaps I can ask him back whether he has experience, whether this is tolerated well, because I would expect local side effects from the steroid administration subcutaneously. Personally, I have no experience with that.
Okay, so Thomas, if you want, you can write back and I will read your answer. I think the group of Genova several years ago actually tried some depot medications and without very clear success.
Thank you for that.
I don't have also any. I'm not aware of any other studies. We have a last question from Iman Nureldin. Does very low level of serum albumin alone, even in the absence of severe edema or oliguria, warrants IV albumin infusion?
No, I would say no, because the albumin infusion I would go for if there is treatment-resistant edema or if edema is really severe and potentially life-threatening. So a low serum albumin alone would, in my opinion, not justify albumin infusion. Not in the initial episode of serosensitive nephrotic syndrome. So we are not talking, of course, about congenital nephrotic syndrome here. We are talking about idiopathic nephrotic syndrome.
All right, so I think this brings this webinar to an end. Lutz, thank you again for this very interesting and participated webinar. I remind to everybody that the next webinar will be on June 4th, and that Rosa Vargas will talk to us about monogenic causes of hypertension. And again, thank you very much. Goodbye.
Thank you, Francesco, for moderating. Thank you all for listening. Bye-bye.